We could spend days, not hours, talking about the potential treatment options for patients who are in need or seeking treatment for prostate cancer. For those patients who have localized disease, previously we used to say, well, there's the surgical option of removing the prostate, there's radiation options, which is a huge Chinese menu of options in itself. And now we're starting to realize that some patients have prostate cancer only on one side of the prostate, and we now have come into this realm of minimally invasive treatments, these focal therapies. When you talk to a patient, how in a 20-minute consultation do you cover all the potential treatment options? Surgery, radiation, focal therapy, no therapy?
Well, unfortunately, my consults run 60 minutes, which is why I put in a long day. I always tell them, look, you have 3 options, and these are really, we try to simplify it, but you're right. Each one has a long menu of nuances. But the first one is active surveillance. We're not going to treat you now. You can avoid the potential side effects, but you do have to follow up PSA, repeat biopsies. Option number 2 is surgery. You know, having a prostatectomy to surgically remove the prostate gland makes a lot of sense for patients that have a long life expectancy. So if you see a patient in their 60s that are really healthy, based on the actuarial tables, that patient's going to live 3 decades. And that's a long time for even a very low risk, low volume cancer to grow. Those patients should consider surgery, and we can talk about the robotic prostatectomy versus the more standard one, although these days most surgeries are being done robotically. But I go through the possible side effects, so the erectile dysfunction, the possible loss of urine control, and if a patient says to me, look, I just want to live, do what you got to do, especially in the younger patient, I think it's appropriate. I think those patients should have surgery, because when we look at the comparative studies of either active surveillance, surgery, or radiation therapy, they really don't go out to about 10 years. We're seeing some early studies 15 years, but most of the studies are 10 years. So if a patient is 70, I'm comfortable with other options. But if someone's 50 or 60 years old, surgery is probably the way to go, unless they're not comfortable with the possible side effects.
Now, we've talked about the potential side effects. We've touched on the issue of issues with sexual function and urinary control, and patients obviously may be keen to avoid those if they can, but not every patient is eligible for surgery, even regardless of side effects. So for those patients who may have issues with anesthesia, they may have an extensive cardiac history, they may have significant obesity that may be a contraindication to surgery. What other options are there for those patients?
So certainly the 10-year and now early data on the 15-year results show that whether a patient has surgery or radiation, the survival is the same. And so for patients that are not comfortable with the concept of the sequelae, or as you say, are just not candidates for the surgery, then we offer radiation therapy. And radiation therapy, the broad categories are either external beam radiotherapy or internal, what we call brachytherapy, interstitial. You know, the external beam therapy, there have been tremendous advances over the past few years. We now use what's called image-guided radiotherapy, where you can really pinpoint the radiation to hit only the prostate gland. And we use sophisticated techniques, computerized, matching up with a daily CAT scan, so you know exactly where the prostate gland is. So you don't have to put a wide margin around it, thereby you avoid hitting the bladder, avoid hitting the rectum. That's in the older studies, that's where most of the side effects came from. So if you could do image-guided radiotherapy, it's typically about 9 weeks, those patients do extremely well. Some patients will opt for internal radiation, so seed implantation. It's about a 45-minute procedure. We implant radioactive seeds, and they can do very well. And a well-delivered interstitial implant with radioactive seeds, patients do very well. The 10-year results look just as good as external beam or surgery.
So for the potential side effects from radiation, you've already mentioned the bladder side effects. The bladder is obviously above the prostate and the rectum is behind, but with the advances in radiation protocols and of course the machines and the whole imaging, that's really helped to significantly reduce the side effects.
Sure, I think with image-guided radiation, what we're not seeing, we don't see incontinence. So that's the major issue. You know, patients are considering surgery, they have to think about the sexual side effects and whether they're going to have incontinence if they cough or bend down while they wet themselves. The incontinence does not happen with radiation therapy. Somebody that has urge incontinence, perhaps that makes it a little bit worse, but someone that's not having an issue with incontinence won't have one after the radiation. But there are sexual side effects. At least 30% of men that go through radiation therapy will end up with sexual dysfunction because the blood vessels that provide blood to the penis get narrowed. Now, there are medications for that, but I always tell a patient going in, you gotta think you're gonna be in that typical scenario where 30% of men have problems.
Now, you mentioned radiation, external beam radiation, which treats not only the prostate itself, but also the bed of the prostate and the surrounding tissues. And we've talked about the seed therapy, the brachytherapy that can go inside the prostate. Is there ever a value for offering patients both combination seeds and external beam?
Absolutely. Sure, patients that present with more advanced disease, there's some very compelling data that a combination of hormone therapy, we haven't discussed yet, but medication to shut down the testosterone, external beam for several weeks, typically about 5 to 6 weeks, plus some form of implant, whether it's seed implant or we call a temporary high dose rate implant, that the control rates are much better than external beam alone. You know, by combining some dose from the outside and some dose from the inside, you can achieve a tremendous dose that you couldn't give if you just use one modality. That's more for men that have Gleason score 8 or higher. I think someone with Gleason score 6 or 7, either external beam alone or seed implant alone is probably sufficient.
And I think there's some newer data to support seeds alone for patients that are in this slightly less risky category. Absolutely. Many patients are very concerned that radiation itself can cause cancer. How do you answer that question, and is that a real concern for patients?
It certainly is. I mean, I think that, you know, we all know that based on evidence from Hiroshima and Nagasaki, that radiation therapy is a carcinogen. And that's certainly true for full body or large parts of the body getting exposed. I think that, you know, whenever patients consider radiation therapy, they've got to weigh the benefit and possible risk. So the benefit is you've got a prostate cancer, we want to treat and cure it. What's the risk? Is there risk for getting bladder cancer, rectal cancer? It's not clear. If you look at the large population data, where you take tumor registries from a large state and look at it, there's no clear cause and effect from radiation therapy. And that's not subtle. You know, unfortunately, we treated teenagers with Hodgkin's lymphoma, and they ended up with getting recurrences, and they got radiation therapy. A lot of them ended up with breast cancer, lung cancer. So typically, you'll see that within 5 to 10 years. Now, we treat hundreds of thousands of men every year, and we're not seeing a large proportion of those men coming back with bladder and rectal cancer. So that's how I lay out the risk. What I tell patients is that the risk is so low, you can't really express it in one man. You've got to look at population statistics. I think it's fair to say if you take 1,000 men that have never received radiation versus 1,000 men that did, the relative risk is somewhat higher in the group that got radiation, probably about 1.2, 1.3, that they're going to have a higher risk. But if I pull out any one man from that population, I can't tell you you've got a 2% or a 5%.
Sure.
And that should be reassuring.
I think as well the problem is often the fear of these potential risks that are more theoretical are actually much more, they encourage patients to delay treatment, which can actually really change the course of their disease. And I'm sure you must see that all the time, delayed referrals, when we know that with many types of, many scenarios with prostate cancer, if the patient gets the radiation treatment early on, the outcomes are better.
No question about that. I think, you know, unfortunately, because it's such a prevalent disease, everyone knows someone. So when I see a patient, it's their brother-in-law, their barber, their friend from the gym. They know someone that's gone through it. So that makes it a little bit more reassuring. But these are real concerns that patients have. And these are important questions that everyone should ask their physician.